has the goal of bridging exciting developments in biology and engineering with medicine, bridging the gap. I call your attention that the final session of this course will not be next Tuesday, but the following Tuesday, May 17th. And we're delighted that Francis Collins will speak on the role of the NIH in science and health. Quo vadis? Where are we going? And that will be at 4 p.m. on May 17th. You can access it as you have access today's through the videocast.nih.gov. For those who have attended at least 50% of the sessions and seek a certificate, you have to pass a final exam, which will be posted next week. It's a multiple choice exam. I don't think it's anything you're going to lose much sleep over in taking. And the website is listed on the slide, and that's where the exam will be posted. Physicians who seek CME credit, please note that the number for today's session is 38657, 38657. Now, we're really fortunate that a young lady will be a patient, who is a patient, will present her story in the beginning of today's session. And then we will have a question and answer period following her presentation. So I urge you to submit questions during the presentation, and you do that by clicking on the Send Live Feedback on the videocast display. Please note that all previous sessions for the past 21 years are archived on the site listed on the slide. And if any of you have any additional information or request for information, please get in touch with me. Next slide. Now, this is a course in bridge building. And during the year, we have bridged extraordinary gaps to space, to biotechnology, to a great variety of areas, including language. But the principle, the main activity in demystifying medicine is basically replicates what used to be, we've referred to as old-fashioned grand medical rounds. A live patient tells something about their disease, and as someone pointed out, puts a human face on the disease. And then a physician scientist describes about what the disease is and what they're doing about it. And then a basic scientist tells us more or less what we know, what we need to know, and that's followed by a robust question, answer, and discussion. And so these two gentlemen on the bridge are discussing what is it about the benign tumors of children. Some of them turn malignant, some of them are inherited, some of them produce local effects that require treatment, more often than not surgery. But some of them present problems that cannot be addressed by surgery. And what, if anything, can we do about them? And are they precursors of malignant disease? Now, these are a tumor, the word for tumor is oma. So we have fibromas. Today we're discussing fibromatosis. But there are also various neuromas, meningiomas of the nervous system, which is more or less today's focus. And there are complexities of these diseases, some of which are inherited and are manifested in children and young adults, where they have been described clinically and pathologically. And aside from surgery, very little has been possible in the way of effective therapy until today. And so, next slide. Today's speakers are responsible for tremendous advances in understanding the molecular basis of neurofibromatosis type 1 and their interest in other such tumors of children. Some of the characteristics on this slide will be discussed in much greater detail, so I'm going to skip over it. Next slide. So our speakers, the first is Bridget Widemann, who graduated in medicine from the University of Cologne in Germany, where she took a pediatric residency, and then came to the NIH as a pediatric fellow in hematology and oncology. And we're all delighted that she stayed here ever since. She achieved tenure in 2009 and currently is the NCI head of pharmacology and experimental therapeutics section. She's the chief of Pediatric Oncology Branch and a clinical deputy director of the Center for Cancer Research. Now, her major interest throughout her career is the development of early clinical trials for children and young adults with refractory cancers and genetic tumor predisposition syndromes, such as the one to be discussed today, neurofibromatosis type 1. Within the past year or two, her work and with her colleagues has attracted enormous attention and appreciation. They're responsible for the first FDA-approved treatment for neurofibromatosis type 1. And in 2021, she received a highly prestigious award within the top 10 clinical research awards from the Clinical Research Forum. This is a big deal. She was also elected to the Association of American Physicians and gave an outstanding astute clinician lecture here at the NIH. She has her part in developing multiple clinical trials of new investigational agents in pediatric refractory cancers, as well as in neurofibromatosis type 1. The second speaker, next slide, is Jack Shern, who graduated in medicine from the Medical College of Georgia, took his pediatric residency at the University of Chicago Children's Hospital, and then trained in pediatric hematology and oncology at NIH in the NCI. He's in the Cancer Research Genetics Branch, where his main activity is the development and application of next-generation sequencing to profile somatic changes driving multiple types of pediatric solid tumors. And in 2018, he became an NIH Lasker investigator in the Pediatric Oncology Branch. Well, let us get on to this exciting topic, which I would point out, if you look in textbooks as recently as perhaps only 7, 8, or 9 years ago, these diseases are mentioned and described, but they usually have the additional statement that aside from surgery in some cases, not much can be done about them. We're living in a different world, thanks to research and clinical studies that you will hear about now. So, Bridget, please.
Thank you so much, Dr. Arias. And we really, Jack and I both appreciate the opportunity to speak today. I hope you'll see the slide correctly. And I want to upfront thank my patient Heather and all of the patients who have participated in the research that we're presenting today, because without them, no progress would have been made. The topic.
Dr. Widemann, excuse me, can you please adjust your view? It appears that you're in slide notes, just so we can see your slides full screen, please.
Like this?
Perfect, thank you.
Wonderful, thank you so much. So today's topic is going to be on neurofibromatosis type 1. We have no financial disclosures, Dr. Shern and I, but I will be describing clinical trials with investigational agents that we're conducting at the NIH. quickly, our learning objectives are to give an overview of neurofibromatosis type 1, to talk about the natural history of tumors that develop in NF1. I'll speak about some of the key aspects that we have developed as we develop clinical trials targeting tumor manifestations, and describe progress, but also remaining challenges in the development of effective treatments for neurofibromatosis or NF1-related tumors. And then I'll hand it over to Dr. Shern, to Jack, who will talk about the concept of the tumor microenvironment and its importance in NF1, tools that he is using to define and monitor tumor heterogeneity and evolution of tumors from benign to malignant, and the strategies that we are developing to manage NF1 patients at risk for malignant transformation. We're thrilled to be working at the NIH Clinical Center and at the NCI. In my mind, this is the best place ever to conduct clinical research. And I do want to thank everyone who provides the amazing resources at the NIH, but also within the NCI. And you see a picture of our branch, the Pediatric Oncology Branch here. We are a highly collaborative group, and I really want to thank all of our members in the Pediatric Oncology Branch for their commitment. I'm starting with an overview of NF1. So NF1 is actually a fairly common single gene disorder caused by a mutation in the NF1 gene. It occurs in about 1 in 3,500 people and is inherited in an autosomal dominant fashion. That means if you have a mom or a dad and they inherit NF1 to you, the chances that you'll have it is about 50%. The NF1 gene product, neurofibromin, has a very important function to control the RAS pathway. And many of you know that RAS is mutated in many types of adult cancers. And I'll talk more about this, but when NF1 manifests through mutation in the NF1 gene, that leads to upregulation and activation of this RAS pathway. They're very characteristic cutaneous findings, such as cafe au lait macules. These are coffee-colored spots on the skin, cutaneous neurofibromas that you see on the right-hand side, and also a freckling in the axilla and in other body parts. NF1 can manifest in every organ system. I'm a pediatric oncologist, so my efforts have been focusing on tumors that people with NF1 develop. And my focus in particular has been on tumors, as Dr. Arias alluded to, that arise in nerves. These are plexiform neurofibromas, atypical neurofibromas, and malignant peripheral nerve sheath tumors, in short, MPNST. And when I started this work a long time ago, there were really no effective medical treatments for most of the tumors. NF1 can be clinically diagnosed in the vast majority of patients by the age of 6 years. The typical findings that we see are cafe au lait macules and freckling, neurofibromas, and the diagnostic criteria developed depend on whether you have a parent with NF1 or you don't have a parent. If you have a parent with NF1, you only have to meet one of the other criteria listed here. If you don't have a parent with NF1, you have to meet 2 of the criteria. And the most typical ones that occur most frequently early are the cafe au lait macules. There are many different types of mutations that have been described in the NF1 gene. And it's very interesting that there are only very few what we call genotype-phenotype correlations, meaning that the NF1 mutation predicts for the clinical behavior. So in a family with NF1, for example, the clinical manifestations, even though it's the same mutation, can be highly variable. There's one important genotype-phenotype correlation, and that is when you have a microdeletion, a large deletion of the NF1 gene, these patients are at increased risk for development of aggressive tumors called MPNST or malignant peripheral nerve sheath tumors. NF1 is a condition that develops over time, and I think that's very important when you think from a patient perspective. It is not something that manifests all at one time point, but throughout life. And you see this with the red arrows that indicate Some manifestations start early but develop throughout life, such as the cafe au lait macules, the Lish nodules, hypertension, and malignant peripheral nerve sheath tumors. But there are a few manifestations that we believe are only present or develop during a short period of time, such as the plexiform neurofibromas or bony changes that develop early, but we don't believe happen later in life. But what this means for a patient with NF1 is that they have to be prepared to see changes throughout their life and need to be seen by expert doctors for this reason. I'm now focusing on the peripheral nerve sheath tumors that we see in NF1, and this includes cutaneous tumors that you see on the picture here and here actually on an MRI. These tumors are characterized by loss of the second NF1 allele, so there's biallelic loss of NF1 in the tumor cells. These tumors typically develop during puberty and not in babies or very young children. There are plexiform neurofibromas, and I will talk a lot about these tumors. They can become very large and travel along nerves and branches and can occur anywhere in the body. They are also characterized by biallelic loss of NF1. And then the worst spectrum is these MPNSTs, malignant peripheral nerve sheath tumors that are very aggressive tumors that are characterized by additional genomic changes, and Dr. Shern will talk about this. These tumors require surgical resection, complete surgical resection for cure. And then more recently, we and others have described tumors that are borderline in their biology called atypical neurofibromas that have a characteristic appearance. They're typically round, nodular, have atypical cells, and are characterized by an additional genetic change, loss of the gene called CDKN2AB. And I'm now switching to my patient, Heather, who actually has had all of these tumors at various stages. And it's wonderful that Heather agreed to participate. I will unshare my screen so that we can see Heather. And I will actually ask Heather a few questions about the neurofibromatosis. Heather, thank you very much for joining today.
Yeah, sure.
I know you're busy and we really, really do appreciate it. As Dr. Arias said, people will remember you. They may not remember anything I or Dr. Shern say, but whatever you say, I think they will remember. So maybe if I could ask Heather, can you tell us a little bit of how old you were when you were diagnosed, and do you remember what the findings were when you were diagnosed? Can you talk about that a little bit?
So I would have first been diagnosed with neurofibromatosis when I was 9 months old. So I don't remember a whole lot, obviously, about that, just because based off of my age. But then I do have some vague memories of remembering when I was about 6 years old is when I would have very first started having the actual neurofibroma, like nodules or tumors or lumps or whatever you want to call them, because at that point they thought possibly I had leukemia when they first started appearing. So I have some vague memories of that when I was around 6.
And Heather, what has been your experience growing up with NF1? I know you've had quite a number of complications and events. I don't know if you want to talk a little bit about this, because it is actually quite impressive.
So when I would have been about 14 years old is when I would have been diagnosed with my first malignant tumor, and that was in my calf. I would have been 14, so I was in 9th grade, and I was having a lot of pain in my foot. And one evening, my mom was, with me, and she could see and like feel on my leg that there was a lump there that had changed. So at that point, she had gotten into contact with one of my doctors, and at that point, I wasn't a patient at the NIH yet. So that one would have been removed, and I had radiation to that area. And then I would have been diagnosed with my second malignancy in 2005. And at that point, my doctors who were local to the area that I live in, they referred me to the NIH. So from that point on, I've been a patient of Dr. Wiedemann's. So in 2005, I had the second malignancy, and I would have had both radiation and chemo, and then also that one would have been surgically removed as well. And then I've had several other atypical neurofibromas that have been removed over the years, just as I get scans regularly at the NIH. And so as they like grow and change, different ones are recommended to be removed. And then I just recently had another one removed like a week and a half ago, and we just found out that that one is malignant as well. So they were able to remove the whole tumor, but radiation is what's going to be the next course for that one.
Yeah, Heather, this is really a very remarkable, story, and I feel we've been walking together more or less, but sure. I really, what can you tell the listeners about what it means to be growing up with something where something you can happen all of the time? How do you adjust and actually get on with your life? And I know you are going on with your life.
Yeah.
And many things have changed for you over the last few years.
So I think it's something for me that I've always just learned to just deal with, because it's something I've grown up with, something that I've always had. So I know there's things to be mindful of and different things that, we need to be watchful of. But it's something that I've just always kind of learned to live with and not let it slow me down, not let it stop me. I have a wonderful supportive family too, and that's been huge. And we're, part of a wonderful supportive church as well, and that's been huge too.
Yeah, and I would say you've done a fantastic job in always being available when we said you need to come back, we need to scan you again. I don't know how many MRIs you had, but I'll show a slide that shows that you've been
quite a few.
Yeah, for sure. Heather, what would be, something that you think we should focus on as researchers? Is there anything that you have as recommended?
Well, it would be wonderful if there was a cure for these malignant tumors that could keep them from turning malignant or could stop them from growing, stop them from occurring in the first place.
Yeah, I have to say, if we, Dr. Shern and I, could make one thing happen, that is certainly the top on our list, and we will not stop working. I promise that, Heather, for sure. I also know that you've had some recent changes in your life, and to me that is inspiring. I was wondering if you would be willing to share your recent life.
So my husband and I have become foster parents 2.5 years ago. We kind of started the journey to becoming foster parents, and we were blessed to have a 4-month-old little boy placed into our home. So we got him right before everything with COVID started. And then we are in the process of adopting him. So next week we will be adopting him. So we're really excited for that. He's been a joy and a blessing and keeps us busy.
Yeah, congratulations, Heather. And whatever we do, we'll try to make sure that you can go about your life as much as you can, but we'll be on your side, aiming to help with whatever we can to, keep things under control. And I wonder if there is time now for some questions, if we have questions in the audience.
Yes, let's see. Heather, listen, thank you, first of all, enormously for taking the time, and particularly when you have an infant that you have to take care of. But are there other people in your family who have diseases like this?
So my dad, we would have found out 6 months before he passed away that he as well had neurofibromatosis. So when I would have first been diagnosed, my parents would have had some amount of testing or looked into to some extent if either of them had it. And at that point, they were told that they both were fine. And so I have an older sister who she does not have neurofibromatosis. Then it would be me. And then my next brother, he does not have it either. But then my youngest brother, he had neurofibromatosis as well. And he has passed away too. Whether or not it was a little unclear if his malignancy was related to the neurofibroma or if it was related to something different. Everything went very quickly with my brother and his sickness and passing. So both my family members that have had neurofibromatosis, both have passed away. My dad's death wasn't related to the neurofibroma, and my brother's may or may not have been.
One of our attendees was curious as to whether your disease has been associated with pain. And if so, has pain management been effective for you?
So typically for me, the only time that I've had at least any consistent pain has only been with the malignancies. And honestly, this third one that they removed, I wouldn't say I was having a whole great deal of pain with that one, not anything consistent. So with the malignancies, I've had pain, but other than that, I haven't.
So there's another question, which, how did it happen that the diagnosis, well, when was the diagnosis made, and was it a pediatrician who made the diagnosis? Were you chasing around, seeing different doctors, trying to find out what was wrong? How did that all unfold?
So the diagnosis was made when I was 9 months old. And I think my mom had just started noticing some different changes on my skin. And so she had taken me to the doctors at that point. And from there, we were sent to a specialist at a local children's hospital.
All right. Well, I don't see any more questions. So on behalf of everyone, thank you very much for taking the time to do this. And, you know, we wish you and your family the very best. We're glad that you're in such good hands.
Thank you.
Thank you, Heather. Thanks a lot. I will share my screen again. And please let me know. You see the slides? Okay. I hope.
Yes.
From here, I'll move on to talk a little bit about Heather, who's now, a 35-year-old. And as Heather mentioned, this is really interesting. Her dad had NF1, but wasn't actually diagnosed until later. And we have seen this before because manifestations with NF1 can be fairly subtle. And when you look at Heather, you wouldn't necessarily think at all that Heather has neurofibromatosis type 1, seeing her sitting there. But her dad had also ulcerative colitis, and actually Heather had ulcerative colitis, which is, another very intriguing finding. And as she mentioned, her brother, who had NF1, actually developed a very aggressive malignancy that it was not clearly a malignant peripheral nerve sheath tumors, but a rare sarcomatoid type of tumor that we could not characterize very clearly. As Heather alluded to, she was diagnosed because of the presence of the typical skin findings, and it's something really important for pediatricians to look out for. And then she did have her first low-grade malignancy when in 2001, she was diagnosed with the ulcerative colitis and had a colectomy in 2004. And then prior to coming to the NIH, had her first high-grade MPNST. The question about pain was excellent. I asked this all of my patients. If patients have new pain that wakes them up at night, pain that is severe, we always are concerned that this might be a malignant tumor, even though other types of tumors can cause pain. And then Heather came to the NIH, and I'll talk about this in a moment, to enroll on our NF1 natural history study, where we followed her and she underwent resections 3 times of different types of tumors that we were concerned about. None of the tumors were cancer tumors, but very recently, as Heather mentioned, just a few weeks ago, there was a lesion that we felt was concerning, and that was actually found to be an MPNST. I want to show
you. Excuse
yeah.
me. Can you switch to presentation mode? We can see your additional slides.
Okay, of course. Is this better? Does this work?
1 second. Can you select it again, please?
I swapped the screen, so can you see this slides okay now, or is this better?
Yeah, we're seeing multiple slides.
So do I need to swap
Do a
this?
stop, please. Yeah, stop share and then come back.
Okay.
Thank you.
And now I share my screen again. Is this better?
Select that presentation mode again.
Is this better?
There you go.
Okay. I'm sorry about that. So I'm showing you here a PET scan, which is a nuclear medicine test where labeled sugar is injected into the vein, and sugars go anywhere in the body where nutrition is needed. That includes infections, for example, or tumors. And we're highlighting here in a red arrow an area that is dark, which means the sugar or the dye is accumulating here, and that's in the pelvic area. This is the torso, this is the right leg and the left leg. And then you see here on the screen the pelvis, and you see the right leg and the left leg. In white, you see neurofibromas in Heather's body, and you see a round appearing tumor lesion that corresponds to the dark area on the PET scan, which means an area of concern for us. And this was actually her first malignant peripheral nerve sheath tumor. And on the picture here on the right, do you see my arrow? Okay. You see the tumor on the axial image. In addition, you see other areas on the PET scan circled in black, which are also areas of increased uptake, but not nearly as much as we saw in the malignant peripheral nerve sheath tumor. Heather then joined us for the natural history study. So what you see on the right panel is her age, and you see the volume of each of the individual tumors on the y-axis. And essentially every dot that you see is an MRI that Heather had at the NIH Clinical Center. And as you can see on the panel on the right, most of her tumors grew over time. There's only one in light green that actually had some decrease in volume over time. On the PET scan, on the left, you see circled a number of areas of increased uptake. These are the lesions that we monitor for growth, for pain, and for uptake on the PET scan to make sure that ideally we capture them before they become malignant. And then in the middle, you see an MRI picture. We call this a coronal plane. You see the body, the arms, the legs, and on the left thigh, you see a nodular lesion that appears bright, which is again one of the tumors that we resected, and it was not malignant. Here you see the most recent involvement in Heather, where on the lower panel you see imaging studies from 2019. And on the upper panel, you see imaging studies from 2022. On the very left panel, you see with the red arrow, a small lesion that's just in the area where this scapula is on the left side in 2019. And when you go up to the upper panel, you can see that this has clearly increased in size. And if you look on the right panel, this is the PET scan, where again in 2019, you see a smallish lesion that is bright. This has increased quite a bit on the most recent imaging study. And this is what raised the concern for us that this might be a malignant tumor. And we performed biopsies and then performed surgery. And this was indeed a malignant peripheral nerve sheath tumor. And so Heather will undergo additional treatment with imaging and then likely radiation treatment. This is what we want to prevent from happening, and I'll talk about this more during the talk. One thing that brought me, and this is talking about the treatments that we're developing into the field as a pediatric oncologist, was the fact that the RAS pathway is activated in NF1. And pharmaceutical companies have been developing drugs to block this activation for adult cancers predominantly for many years. And so when I started in the field, and we know that through the mutation of the NF1 gene, we have an upregulation in proliferation and survival signals, that hopefully we could target this easily, I thought, when we started with medical interventions such as farnesyltransferase inhibitors. They block activation of RAS by not allowing it to insert in the cell membrane, or by signaling downstream of RAS that you see here on the left-hand side. But disappointingly, none of this really worked until we identified that MEK inhibitors that you see here in the pathway, RAS, RAF, MEK, or kinase pathway, were really the first ones to show activity in these tumors. And I'll talk about this in the following. And this really holds true for the benign, histologically benign tumor called plexiform neurofibroma. These are benign by histology, develop in very young children. And while benign can cause disfigurement, pain, functional impairment, you can see the growth on the photographs on the bottom and on the MRI in a boy 3 years and 5 years. Clearly, while histologically benign, these are not benign tumors. And our goal was to see if we could understand the growth of these tumors and develop effective treatments. The first thing we did was develop a sensitive method to measure these tumors. And what we do in cancer clinical trials is we do one-dimensional measurements, meaning the longest diameter, or we use the longest two perpendicular diameters. And for the most part, we see progression very quickly or shrinkage very quickly. But for NF1 tumors, the plexiform neurofibromas, which grow more slowly, we needed a method that was more sensitive. And this was developed by Dr. Solomon and Dr. Dombey, and is called volumetric MRI analysis, where we have essentially the area that the tumor encompasses on every single slide. And you see this here in an orbital tumor, where you can see on the coronal plane the slices, and then you see on the axial plane how this program that was developed puts a nice border around each slice that contains tumor. And this allows us to measure the tumors much more sensitively, and we can identify shrinkage or growth more quickly. And so we use this method in two ways. One is on our natural history study, and two is on our clinical trials. And this work was done by Dr. Akshintala, by Dr. Dombey, and also by Dr. Gross. And what you can see on the panel on the right is the age at the initial MRI on our natural history study. Every dot is a patient. And on the y-axis, you see the percent growth or shrinkage of the tumor per year. So you clearly see that the youngest patient had the most rapidly growing tumors versus very little growth that we see in adult patients. That was a very important observation for us, and that's why we targeted with our treatment trials young patients who we hope would get the most benefit from this. In addition, Dr. Gross documented that even at very young age, when the patients came for the first time to the NIH, tumors would already have caused morbidity such as vision loss, pain, disfigurement, and that this was rarely reversible. This shows a slide of my first big clinical trial that I conducted when we really didn't have a good understanding of the natural history of NF1. So this was a double-blinded, placebo-controlled crossover trial where kids with growing plexiform neurofibromas were randomized by the flip of a coin to either receive the drug tipifarnib that we hope would stop the growth of the tumors, or a sugar pill, a placebo. And we didn't know what the kids were receiving. The kids didn't know, and their parents didn't know what they were receiving. We would follow the patients with the MRI until the tumor was shown to be growing, and then cross them over from drug to placebo or the other way around. This study, unfortunately, as I show you on the next slide, on the left panel, did not result in the desired slowing of the growth. You see what we call a Kaplan-Meier curve, which looks at the percent of progression-free survival on placebo in green and on tipifarnib in red. Ideally, we would like to see a line which says 100% survival, progression-free survival throughout, but this was not the case. And you can see that most of the patients developed progression of their disease, meaning tumor growth, and there was really no difference between placebo and tipifarnib. We then conducted a number of additional clinical trials with the goal to improve on this. And you see the Kaplan-Meier curves for the other clinical trials on the right panel. And the best drug was peginterferon, which is an immune modulatory agent, where you can see that we actually improved the time to progression, the median time to progression, to 29 months compared to 10.6 months of the placebo. However, we had tumor shrinkage only in very few patients. And when you look at a chronic condition like NF1, it just didn't seem like this was very encouraging. And I wasn't ready to give up, but it was sobering to see that we had patients who had gone on clinical trials, not seeing clear tumor shrinkage, but clear progression of the tumor, as you see here in the 3-year-old and the 14-year-old. Not only more visible disfigurement, but this boy underwent additional surgeries and received additional pain medications, also developed bowel incontinence. So we clearly felt we need to make progress for these patients. And then we conducted a clinical trial with a MEK inhibitor, which blocks one specific protein, which is the MEK kinase. And this trial showed substantial promise in that every patient had some tumor shrinkage. And you see this on what we call a waterfall plot. This is the plot you see here, where the tumor volume percent change is shown, and everything that is negative, meaning the black bar has a downward trend, means there was tumor shrinkage. We had never seen this before. And we also saw some clinical improvement with improvement in disfigurement, improvement in pain. As you can see in the panel here, we talked with the FDA because we were very excited about this finding and asked the FDA if they would give us what we call breakthrough therapy designation. But the FDA said, look, you're shrinking the tumors a little bit, but you need to show us that patients actually have true clinical benefit from this. So you need to go back to the drawing board and document that in a subsequent clinical trial. So we went back to the drawing board and we designed a larger study for patients who had some symptoms when they enrolled on this study. We used the tumor measurements as the primary endpoint, and you can see on this waterfall plot here, again, when you look at 0, all of the bars, or almost all of the bars, went down, and the red dotted line shows you the number of patients who had more than 20% tumor shrinkage by volume. We were able in this study to show with very meticulous documentation that we saw improvement in disfigurement. And I think you can see this in the boy with the right neck tumor from baseline to cycle 37, which essentially means about 37 months. There's a continuous improvement. And we also looked at patient-reported and parent-reported outcomes. And overwhelmingly, the parents by 86% and the child self-report by 72% reported that there was an overall improvement in morbidities related to their plexiform neurofibroma. And then we looked at patient-reported outcome measures of pain intensity. And this was work done by Dr. Walters and Dr. Martin, who showed that comparing baseline to pre-cycle 13 after approximately 1 year of treatment, there was a clear reduction in tumor pain intensity, which was clinically meaningful, and not only in tumor pain intensity, but also in pain interference. And these findings were very important for the subsequent FDA approval because we were able to document that not only the tumor shrank, but it was clinically meaningful. I want to show you one more example of an 8-year-old girl who was enrolled with a tumor that obstructed the airway. And so she had a tracheostomy to help her breathe. When she was enrolled, on the upper panel, you see an axial MRI of the tumor, and the blue arrows point to the airway. While the tumor only shrank by 25% or so, the airway actually did open up. The patient could be decannulated. She had some further tumor shrinkage and continues on treatment to date without the need for an artificial help. So that was a very major advance for this specific patient. I want to drive one other point home here. This was one of the boys who I had started seeing when he was maybe 5 years old. And you can see, based on the number of treatments, that he was on multiple treatments and his tumor grew relentless. We then started the MEK inhibitor and had some tumor shrinkage, but we had to stop the treatment temporarily because of a decrease in the left ventricular ejection fraction. That means the cardiac function. Even though it was asymptomatic, this is obviously important. We stopped the treatment, the tumor grew back, and then we started back the treatment at a reduced dose. The tumor shrank again, and this patient also continues on treatment to date. But what it shows that this is not a cure. It is something that helps, and it helps substantially. But while the tumors are growing, patients need to be on it, just like on a blood pressure medicine, to really make sure we have a continuous positive effect. I want to spend one moment on the side effects of the treatment. For the most part, the treatment is actually quite well tolerated. While most patients experienced a mild side effect, all side effects have been reversible, and the most frequent side effects have been nausea, vomiting, or diarrhea, a rash, like an acneiform type of rash that you see in the upper panel, and something called paronychia, which is an inflammation around the nail bed, which can look quite aggressive, as you can see on the lower panel. But we've developed very good treatment approaches to this, and so most patients can continue on treatment. This is very interesting data that I'm very proud of from our natural history study. In addition to showing the tumor shrinkage and clinical improvement, this is an analysis that compares in red children that were treated on selumetinib on our SPRINT trial, where you can see that most of these patients had a volume reduction. And then you see an age-matched control comparison for patients on the natural history study who did not receive the MEK inhibitor. And you can see that those patients overwhelmingly had growth of their tumors. And I'm coming back to the Kaplan-Meier curves showing progression-free survival. And you will see in blue that kids on the natural history study had progressive tumors with a median progression-free survival of 1.3 years, in contrast to kids that received the selumetinib, where 84% were progression-free at 3 years. This data was really important towards the FDA approval. And here I'm showing you the comparison of our placebo arm and then patients treated with selumetinib, where you clearly see that we have improved the outcomes. And here you see it in comparison to our other clinical trials. All of this data was submitted to the FDA. And Dr. Arias asked earlier, the NF1 gene was identified 30 years ago by Dr. Francis Collins, our former NIH director, and by Dr. Ray White. It took 30 years then to the first Food and Drug Administration approval of selumetinib, the MEK inhibitor, for kids with symptomatic inoperable plexiform neurofibromas. Today, actually, based on this trial, there's approval in more than 13 countries, and there are more coming. So this marathon, I think, has paid off, but there's a lot more to do. One of the trials that I'm very excited about is a trial that Dr. Andrea Gross will be leading, which wants to look at not only can we reduce morbidity and shrink tumors, but can we prevent them from becoming symptomatic. And if you look at the upper right panel of this little girl at age 11 months and 36 months, you can see how over time she developed a disfiguring left facial tumor. What Dr. Gross wants to do is start the MEK inhibitor in the child when it is an asymptomatic plexiform neurofibroma. And we want to show, can we actually prevent these complications from happening? Her trial is very ambitious. It has 3 parts. In the first part, we will determine what is the incidence of asymptomatic plexiform neurofibromas, and we will use whole body MRI. In the second part, we will have a randomized comparison of asymptomatic tumors treated with the MEK inhibitor or observed. And on the third part of the study, Dr. Gross will look at a different schedule where we give a different schedule and a lower dose to see if we can sustain the benefit. So a lot of progress, I would say, has been made in the tumor called plexiform neurofibroma. I will now talk in much less duration, because we have fewer data, about the highly aggressive malignant peripheral nerve sheath tumors that develop in up to 16% of people with NF1, and also our efforts to prevent the development of MPNST by focusing on the atypical neurofibromas. So MPNST, or malignant peripheral nerve sheath tumors, are aggressive soft tissue sarcomas. Complete surgical resection with negative margins, meaning there's no tumor cell left, is required for cure. In patients where this cannot be achieved, we have done a number of clinical trials, and you see them listed here. Most of them were phase 2 trials, meaning we knew what the doses to give. We wanted to see, do we shrink the tumors or do we slow down progression? Unfortunately, we have not been successful. The trials were feasible, but we have not seen major shrinkage or delaying in the time to progression. And there's a lot more work, and Dr. Shern will talk about this shortly. With that in mind, we have focused on looking at pre-malignant lesions in NF1 tumors using whole body MRI. On the left panel, you see a coronal MRI in a very large truncal tumor without a pre-malignant lesion. And then on the right panel, you see another whole body MRI, where I hope you can detect that there are 3 distinct nodules. And those lesions we believe are pre-malignant. We identify them in patients within plexiform neurofibromas or outside of plexiform neurofibromas. And as the arrows indicate, many of these lesions really appear as distinct nodules. On the PET scan, the nuclear medicine test, they are bright in comparison to no signal in plexiform neurofibromas. And we identified that they develop later in life, not typically in very young patients. I think you can see this really nicely on the upper panel here, where you see a 9-year-old with a plexiform neurofibroma of the neck. If you go all the way to the right, when she's 15 years old and look at the red arrow, there's a distinct nodule that definitely wasn't there at 9 years of age that developed over time and grew quite rapidly. When we removed this lesion with a neurosurgeon, it was an atypical neurofibroma that was in the process of transforming to become malignant. Dr. Dombey and Dr. Akshintala analyzed the growth rate of these tumors, and you see this on the lower panel compared to plexiform neurofibromas. These tumors don't slow down in their growth in older patients. The growth rate is independent of age. And then our wonderful pathologists identified that certain pathologic features make us more concerned for malignant transformation. And these tumors are called atypical neurofibromatous neoplasms of uncertain biologic potential. And many of these tumors have a change that Dr. Shern will talk about momentarily, called CDKN2A loss. And so our focus currently is on surgical resection of these tumors prior to them becoming malignant. I show this in, again, one more example to drive the point home in a young man who had total body burden with neurofibromas, but he had an upper arm atypical neurofibroma that I hope you can see in the upper panel. Volumetric analysis showed that this was growing slowly over time. And again, with the hypothesis that this is the precursor lesion for MPNST, we could not predict when this happened, but this tumor did transform to become malignant. And you can see in the red line, it grew much more quickly all of a sudden. And so we're struggling with when is the right time to intervene and how can we predict for malignant transformation. So Dr. Gross and Dr. Sunby in the POB are working with me on developing a new natural history study that will focus entirely on better characterizing the malignant transformation and developing interventions, which will include surgical resection with our wonderful neurosurgeon, Dr. Prashant Chittiboina. And this study is in development and will hopefully inform this process so that we make more progress. And I'm very pleased that Dr. Shern is going to talk now about the amazing work his team is doing to help us understand the biology and hopefully make more strides in the prevention of MPNST and treatment of MPNST. So I will stop sharing my screen so that Dr. Shern can take over.
Thank you, Brigitte. And I am switching over here. Let's see if I can get it into presenter mode. How does that look?
Perfect.
Great. So thank you, Dr. Widemann, for sort of setting me up to tell you the crowd about what we're working on in the laboratory to sort of follow up on some of these studies that have been so successful in the clinic. I'm a clinician scientist. I'm a pediatric oncologist, and I work in the Pediatric Oncology Branch here at the NCI. And I was starting my laboratory as a cancer genomicist right about the same time that next generation sequencing was sort of coming online. So I spent a lot of time sequencing tumors and looking for the changes in tumors over time. And when I started my lab, I sort of was struck by this disease because I think it is such a tremendous teacher of 2 points. They're related, but I think they're just so important as we study tumors and how they evolve in patients over time. And the first point is that there is a genetic tumor progression. Dr. Widemann has laid out beautifully this clinical progression, but also, I think that this has to be encoded somehow in the genome of these cancer cells that allow it to progress over time. And so that was a great interest to me. And the second point is that these are massive tumors. These benign plexiform neurofibromas are absolutely massive in some of these patients. And you can imagine that there's a large degree of tumor cellular heterogeneity, that these aren't necessarily clonal progressions in all the cases, but there's actually a diversity of cancer cells, immune cells, stromal cells that make up this tumor microenvironment. And I think this is critical sort of going forward in how we understand this disease. So I'm a cancer geneticist, and this, again, is sort of an elegant demonstration of how tumors evolve over time. And so I'll just walk you through in a little bit more detail in what Dr. Widemann has sort of set up here, is that these patients with NF1 have a germline mutation in one of their alleles of NF1. So they are set up like this with RAS pathway activation. You've heard that these were first described in 1990, and Francis Collins was one of the investigators that was initially involved in the discovery of these genes. The plexiform neurofibromas took a little more time to figure out, maybe another 10 years or so before we realized that it was a unique sort of loss of the other allele of NF1 that caused this specific change in these patients. And then, I think I can jump sort of over to the MPNST side of things, because we've really had an explosion of information about what happens in those tumors. We're seeing things like TP53 mutations, alterations in 2 genes, EED and SUS12, which are involved in the polycomb repressive complex, this epigenetic complex that's in these cells, and then wild aneuploidy. So, by the time it becomes an MPNST, it's really, quite genetically different than these simple plexiform alterations. And then as Dr. Widemann just laid out, we think that there's sort of an intermediate couple steps here. And one of the initial steps that has been discovered is the loss of this tumor suppressor CDKN2A. And usually this is one allele of CDKN2A, but sometimes it's two alleles of this. And so understanding this genetic progression has multiple or presents multiple opportunities for us in the laboratory. The first one is that you can really start to build powerful mouse models. And in some ways, NF1 has been somewhat lucky because the NF1 mouse can mirror very well the human condition. And so you can imagine that multiple people now have started to figure out ways to knock out the NF1 gene at multiple different time points in multiple different cells across the mouse, and then see what the different phenotypes are. Do they match what we see in the patients? So, here on the left, you can see that, there are now multiple NF1 mouse models. Some of them make plexiforms. Some of them make plexiforms in specific parts of the body. Some of them make other tumor types. But this has been a powerful tool. And one of the key findings that I think is really interesting is that to get these plexiform neurofibromas to grow, you actually have to knock out the NF1 gene at a specific developmental time window. So you actually have to have the second allele lost in an embryonic or early postnatal state. And that's what these sort of diagrams are showing here, that this is a timing effect and that it probably happens pretty early in these patients. This is one of the models that we've used, and this was developed by Nancy Ratner's group at University of Cincinnati Children's Hospital. And what she did is sort of have a very developmentally restricted gene, this DHH gene, driving and linked to the loss of NF1, so that only the Schwann cell precursors, when this DHH came on, lost their NF1 alleles. And you can see what this did then. It started to develop tumors. They're not fast-growing tumors, but they're very similar to the human tumors. In this panel here, you sort of see what the wild type spinal cord and the peripheral nerves that are coming off of it look like. And here's what this looks like in the NF1 DHH Cree model. So you can see these big, large, benign tumors. Some of them have hyperpigmentation, which is very, again, similar to what we see in the human condition. And so what can you do with this sort of thing? Well, Dr. Widemann showed that beautiful clinical trial where we discovered that MEK inhibitors were useful in treating plexiform neurofibromas. If you have a mouse model that mirrors the human condition, you can run these experiments in the mouse and then take them to the clinical trial. So that's sort of the model for how this works. And you can see here that the mouse is treated very similar to the human. We're following these large benign tumors with MRI scans here, and you can treat with different doses of the drug. In this case, this is a MEK inhibitor called PD. And you can see in the control group, the plexiforms continued to grow in the mouse. And if you used more and more increasing doses of the MEK inhibitor, you got a shrinkage of those tumors. This is really powerful because now you can imagine that all those failed clinical trials, what if you have the right model, you could test these things in the laboratory before going into the patients. The second point is we now know that there's a second step. So that CDKN2A tumor suppressor loss comes after the NF1 loss. Now you can make a mouse that models that. So in the right panel here, what we're showing is a mouse model that was developed by Wade Clapp's group at Indiana University. And here you can see we're mirroring very similarly the atypical neurofibromas that Brigitte was talking about. By knowing the genetic hits that happen in the human, that allows us to build these mouse models. So this is a very powerful tool, but it has really only come online just recently. So, the progress that was made in those early plexiform trials, now we're developing the tools that we can start to make progress in the atypical neurofibromas. So On the far end of the spectrum, of course, is the MPNST, those bad malignant players. And sure enough, if you know the genetics of those tumors, you can again build mouse models. And this is work done by Karen Chakowski, and using a mouse model where you have loss of NF1 and loss of TP53, another tumor suppressor that we see mutated in MPNSTs. And these tumors very nicely mirror the malignant peripheral nerve sheath tumor, the MPNSTs. And so we follow the same model where you can test different drugs or different drug combinations in the model that matches the human condition. And here, Dr. Chakowski has sort of come up with a combination of a MEK inhibitor plus an mTOR inhibitor. And what you can see is when you combine those things, you actually get some synergy. It's actually interesting that if you use the MEK inhibitor in the MPNST, it doesn't really respond at all. And we see that also in the patients. Interesting correlations between the clinic and the laboratory here. This is actually turned into a clinical trial that we just completed. This was run by Dr. Kim, and we were one of the participating sites. And so we've recently just been able to sort of push this through into patients, again, following that model. And we always have our eye on sort of the next thing, right? So what is the mouse model sort of telling us we should bring to the clinic next? What's most likely to work? And again, this same mouse model was used to sort of show this, that there's a combination of two inhibitors, a MEK inhibitor and a bromodomain inhibitor, that caused synergistic tumor regression in the mouse model. Sort of interesting finding about this is that it actually seemed to unleash sort of an immune response when you added this combination to a checkpoint inhibitor, a PD-1 checkpoint inhibitor. And this really now, you can see in the red over here, when you add the MEK inhibitor plus the bromodomain inhibitor and then unleash the immune environment, you really get shrinkage of these tumors. And again, let's follow the same model. Let's take this into a clinical trial. And so what the mouse is teaching us, it was learned from the human tumors originally, and now we can take those again back into the human. And that's our model for how this is going to work. But, I think Heather, our patient, sort of made the point, really, I don't want to get MPNST at all. If I could get one thing, maybe it's just to stop this progression. And you heard some of Dr. Wiedemann's strategies. Let's do surgery as quick as we see these things. Let's develop medical therapies, and Dr. Gross is working on medical therapies to treat these atypical neurofibromas before they make that jump. But one of the things that we've sort of had some success in the recent times is, what if we could detect these things early? What if we could sort of predict the time point when those malignant transformations are happening? Wouldn't that be a useful tool? And so, this is, not a surprising strategy, but in some ways the technology has advanced to the point where we can start to do this. And Dr. Widemann showed you very elegantly that right now, what we do in the clinic is we diagnose these things clinically. The patient will say, oh, this is actually a little bit more painful. Let's take a deeper look at that. Or let's scan head to toe with an MRI, and let's do it every year. And you can imagine that that's not particularly sensitive or specific, because we think these MPNSTs are developing within the bigger plexiform neurofibroma. Now, we could also sort of stick a needle into every area where we're concerned and take a piece of that tissue and look at it, but that's got significant morbidity as well. You don't want to be doing a bunch of procedures in these large benign tumors, especially for no reason. So that has a high predictive, positive predictive value. But you can also stick the needle just to the right or just to the left and completely miss a diagnosis. So what we've done in my group is sort of say, what if we had a test or a blood test? Let's look in the plasma and see if we can see evidence of these changes. And this is work that's been led in my group by a very talented clinical fellow, Taylor Sunby. And he sort of came up with the idea, well, it seems like aneuploidy is, a very common feature of the malignant transformation. When it becomes an MPNST, we see a lot of aneuploidy. And just to remind you what aneuploidy means, in tumors, you get gains and losses of chromosomes. The tumor really sort of can add multiple copies of individual chromosomes. Instead of the normal sort of diploid state, you can have wild gains of different chromosomes and losses of other ones. And if you look at the progression from plexiform neurofibroma to atypical neurofibroma to MPNST, these sort of increase exponentially. So they're becoming, more and more a feature of the MPNST. So we said, okay, well, we need a blood test to detect these aneuploid events. And what we did is really just collect the patients that were here at the clinical center. We took some healthy volunteers. We took patients that had just benign plexiform neurofibromas and patients that had malignant peripheral nerve sheath tumors. And a group at WashU, who were great collaborators with us, did the same exact thing with their patients. And then what we do is we take the plasma from these patients and we spin it down and isolate the DNA. And we do whole genome sequencing. So we look at very shallow sequencing across the entire genome. And what this does is it allows us to do a couple things. We can predict the aneuploidy copy number changes. We can correlate this with the clinical findings and the imaging findings. And then another key feature is this sort of cell-free DNA fragment selection. I'll just briefly touch on that. But this is what this looks like. And this is, to me, pretty striking. If you sequence the tumor DNA, normally this should be right along the 0 point. That's the diploid genome. You can see this in the genomic DNA. Here's the patient's germline DNA down here, nice and flat. If it becomes a tumor, you see these wild gains and losses of different chromosomes, chromosome 1, chromosome 2, chromosome 3, on and on and on. But if you sequence the DNA from the plasma, sure enough, you can see some of the tumor DNA that's shed into the bloodstream. And that's what we see here. And you can see it very nicely mirrors the changes that we see if you just look at the tumor. So here, now we have a biomarker. And this is actually pretty powerful because even if you give a patient therapy, start to shrink their tumor, this is the change. You start to see it go away. And so that's a really useful tool clinically, because now you can sort of follow the patient, or you can follow the patient when they're in the benign state and look for these sort of changes. And if you see these changes, you might want to be worried that this is transformed somewhere. A powerful sort of adjunct to this was this discovery here, that the size of the genomic fragments that we were finding, if they came from the tumor, were a little bit shorter. And this has been seen in multiple tumor types now, where the tumor seems to shed smaller fragments of DNA. And nobody's quite clear on why this happens, but it's a recurrent feature in multiple tumor types. So we could actually filter this and make it a better test by just looking at an area of sequencing reads that were a specific length that was much more enriched for the tumor DNA. And this was a powerful way to improve our assay. And what we came up with was this: if you started to look at this compared to things that we normally do in the clinic, like anatomic MRI, which has a sensitivity of 90% and a specificity of 61%, we were just as good, if not a little bit better, using our cell-free DNA ultra-low pass whole genome sequencing. And if you had multiple samples from the same patient, it actually got better. And so we continue to refine this assay right now. But I think this is a really exciting way that you can imagine incorporating this into your patient, your clinic, where you have multiple NF1 patients. And instead of scanning them head to toe with an MRI every year, you would get a blood test and look for these changes. The really powerful thing that we saw over and over again is that the cell-free DNA assay was picking this up before the imaging. And that's perhaps not too surprising because you can only do imaging so often. but you can take a blood test pretty frequently. So I think this is sort of, early days with this test, but has huge potential in these patients that have a germline predisposition where you're very likely to get a tumor at some point in your life. And just again, this assay actually mirrored the treatment course for the patient. So if you gave a successful treatment, the cell-free DNA assay would come down. And if they were recurring or the disease was progressing, it would go up. So again, you could think about incorporating this into a clinical trial where if the patient, you don't wait for the patient to sort of blow through whatever therapy you're giving them. You can follow them over and see how they're doing and progressing. And maybe that would allow us to sort of titrate the therapy more rapidly. I want to just switch gears here for the second idea that came from these tumors and what these patients are teaching us is this importance of tumor cellular heterogeneity. And I grew up in the era where we were doing bulk sequencing of tumors. We would take the tumor, grind it up, extract things like the DNA and the RNA, and then that would sort of be averaged out. And the analogy's been made that that's sort of the fruit salad type approach to sequencing. We're in an era now where the technology has progressed where we're starting to do single cell sequencing. And here you can imagine in a very diverse microenvironment with multiple cell types that you could start to tease apart different cell populations and then study those in detail. And I'll give you some examples how we're doing that. Now, again, this is the perfect patient setting to do these things because these are, again, massive tumors. You see this gentleman here with a massive left arm tumor. It's a plexiform neurofibroma, but in fact, he came to us because he was complaining of some pain sort of in that upper part of his tumor. And you can see there's sort of a distinct nodular area there. They say that there's about 10 to 100 million cancer cells within a 1 centimeter cubed tumor. And here we're measuring these tumors on the volume of liters. So this is a massive tumor. And you can just imagine that if you did biopsies in multiple places along here, you get different answers. So this is one of the benefits of working here at the NIH Clinical Center, because we can enroll these patients and study their tumors in depth across them. And what you see is that at every stage of these tumors, there are distinct populations of cells. There's immune cells. There are certainly tumor cells. There's stromal cells that are making this thick pink matrix that you see in these H&E slides. But the theory is that every one of these cell populations is contributing to that tumor's growth. It's the microenvironment that allows that tumor to continue to grow. And the cells within there are sort of working together and coming to some balance together. And you can imagine that every one of those cell populations then becomes a potential therapy. And again, we live in sort of this age when immune therapy is becoming more and more successful. So you can imagine characterizing the T cells that are within these tumors becomes an immediate therapeutic potential, or the macrophages that are present in these tumors. So again, these are sort of immediate ways to make a potential new therapy or a therapeutic strategy. And then, I think you really have to understand this complex environment to understand why your tumor is progressing despite the therapy you give. Why is the MEK inhibitor only work to shrink the tumor on average about 30%? What's still there? What are the cells doing that are still there? And that's, I think, the key questions that we're starting to answer now. Again, you can see in these tumors, the small round blue cells are usually immune cells, maybe some big fibroblasts within there. And the tumor cells we know are sort of these long, elongated nuclei here. And so you can see they've wrapped themselves in this really pink matrix, which is extracellular proteins and things that are made by the fibroblast. And people have understood this for a long time, and have tried to think about ways to sort of target this. And the current, at least, basic understanding of this is that there's a neoplastic Schwann cell. It's secreting certain factors into the tumor microenvironment. This recruits immune cells like macrophages, mast cells, which in turn feed back and deliver growth factors back to the neoplastic Schwann cell. But certainly you have the neoplastic Schwann cell also talking to a fibroblast population of cells that's making this dense collagen and extracellular matrix. Understanding this, these interactions, again, I think is key to making the next set of therapies for these patients. And this is what we've been working on in my laboratory. This has been led by a really talented postdoc named Shiwan Zhang. And the idea is we're going to create sort of a single cell atlas of all the cell types that are within these NF1 nerve tumors. And so again, having the natural history study in the clinical center here, we're able to collect these patients and then sequence by single cell RNA sequencing. What you see here is a UMAP plot, and every dot within this plot represents the gene expression profile of an individual cell. And so what you see here are there's lots of dots on this plot, and this comes from 56 unique tumor samples that we've been able to collect, 49 individual tumors, and at this point about 500,000 single cells. And sort of the rewarding thing of doing these type of experiments is you can sort of quickly start to define cell populations based on their gene expression profiling. So now you can say, okay, well, these guys in pink are the malignant cells. Here's the malignant Schwann cell that's in a plexiform neurofibroma. Here's all the lymphoid cells that are within this big map. Here's the myeloid cells. Here's the endothelial and the perivascular cells. And here's the fibroblast. And what you can see is by gene expression profiling, you can start to subcluster within individual groups. And you can take this to the next level, follow that same progression, where you can look at, just give me all the cells that came from a patient that had a plexiform neurofibroma or an MPNST. And you can see the very different profiles that you see in the MPNST. And if you sort of summarize this, the obvious one is this big pink region grew in the MPNST, and that's the tumor cell. So not surprising. But what you can also see is within the MPNST, there's some unique immune populations of cells. There's a new target. Look at this cluster on the fibroblast population. Here's a unique fibroblast that's very specific to the MPNST. And so again, this sort of opens up new ideas and new ways to engineer ways to go after this. One of the things that sort of struck me is how similar the atypical neurofibroma was to the plexiform neurofibroma. You certainly get expansion of this sort of purple group. Not surprising, again, that's the tumor cell population, and a contraction of the myeloid immune cells. And so, I think those two, the atypical and the plexiform neurofibroma, that's a very fine change. When it goes to the MPNST, it's wildly changed. And, I'm a cancer cell biologist. What I'm really interested in is sort of that malignant transformation of the cancer cell. And you can follow these cells now. So you can look in the plexiform neurofibroma, single cell resolution level, look at the gene expression profile of the cells that are sort of dropping out of the atypical lesion. And then as this becomes an MPNST. And one of the things that sort of struck us right out of the gate was if you just take those Schwann cells and recluster them, this is what the map looks like. Again, every dot is an individual cell representing their entire gene expression profiling. So what you can do with this experiment, you can sort of see that there's, clearly sort of a plexiform side of the Schwann cell group and an atypical neurofibroma side of this thing. And that change is what we see in the patients. And I think that represents a basic understanding of this tumor that we have to come to grips with. And one of the markers that comes out of this analysis is CDKN2A. And what we found is that there's a sort of a finding that doesn't make sense right out of the gate, that in the plexiforms and in some of the cells in the atypicals, CDKN2A is actually really highly expressed. In fact, it's a biomarker of those cells. So that doesn't actually fit with our model, right? We expect CDKN2A to be gone. And sure enough, if you look at the atypicals, you have a real large number of those cells, no CDKN2A. That fits the model. But what is this CDKN2A high population? And, I think it comes down to this experiment here. And this is sort of another unique point where this sort of resolution can give you a target. And this is, again, work done by Wade Clapp out at Indiana, where if you take just NF1 lost cell Schwann cells and culture them, what you see is not surprising. You aren't able to detect any neurofibromin. The cells grow, but like the patient, they don't grow super rapidly. They grow a little bit worse than or a little bit better than the wild type. But if you stain with beta-gal, which is a marker of cellular senescence, the NF1 knockout cells have a lot of senescence. So those are cells that are trying to arrest. And you can see this at the mRNA level, where if you have the knockout cells, their CDKN2A expression goes very high. And you can see this at the protein level as well. And, I think this is my sort of last couple of slides. I think having this sort of resolution is revolutionizing how we can think about this. And the patient's samples are teaching us that maybe the mouse model kind of skips a step. And maybe we're missing part of the picture here. Because if you follow the CDKN2A level, as it moves from plexiform to the atypical or the MPNST, it actually goes up and then it goes down. And so what I think is the mouse model actually skips this, because over on this side of things, I think that's the genetic deletion. What I think is happening here is, if you lose NF1 as a Schwann cell, you actually want to senesce. You want that cell to stop growing. And that's exactly what it's doing. And I think these are the atypicals, where they sort of stop growing. They sort of sit in place. They have very few mitoses. They lose sort of their cellular architecture. They might be nodular at this point, but CDKN2A is genetically intact. Within that tumor, one of those cells will have a genetic event that deletes CDKN2A. Just by that number of cell divisions, that's going to happen. And that's the cell that allows it to jump off the edge here and progress towards the malignancy. And so again, you can start to come up with, all different ideas and questions about, well, what caused this sort of change? What is the cell trying to do? Is it really trying to arrest? Or is it happening because these tumors are constrained? Or is there some sort of cellular stress? Could we try and get rid of those CDKN2A high cells, prune those away, because those are the ones that are at risk for falling off the other end of the cliff? And then, is it really true that one cell or maybe a handful of cells will lose that CDKN2A locus? And that's the progression that sort of leads to rapid progression down the malignancy pathway. And then, I think clinically, can we use a drug? Can we use a drug to sort of reverse this effect and push things back towards, where things are a little bit less likely to transform into the malignancy? So that's what I think, tumor heterogeneity is teaching us. And this resolution of single cell allows us to start to come up with these sort of ideas. So just to finish up, we have some take-home messages. NF1 patients are great clinical teachers. They're the basic researchers to teachers, and they're clinical teachers. And you've seen that in Brigitte's presentation and hopefully in mine. The NIH Clinical Center has been a powerful place to study these natural histories of these diseases. And, uniquely, NF1 is a great teacher because the clinical progression is mirroring so beautifully this genetic progression. We think we're making great progress on treating the benign NF1 tumors, But once that transition to malignancy occurs, the prognosis is pretty poor. Early detection and prevention of MPNST may be an achievable goal. And I think the technology, again, is moving rapidly enough that we should have these things in the clinic soon. And then finally, patient engagement and collaboration are critical to making advances here. And, our patients are the ones that taught us originally, and they're teaching us again and again how to do this better. And this is a picture from Camp Fantastic that we run for some of our patients, where we take them out to have a summer camp, and it's great fun for everybody. And we have, this is Brigitte and my sort of acknowledgements. This is a huge team of people that have done most of this work, and we're just here to sort of deliver the message. But there are lots of people behind the scenes and who have been great collaborators to us over the years. And I guess I'll stop there, and we can open the discussion.
Okay. Well, thank you both for exciting is too minimal a word to add to the enormous work presentations and the dimensions of what the future may hold for this. It struck me that this is an interesting example. It used to be that clinical observations of people taking drugs much later led to the mechanism of how a drug acts. And this is modern science somewhat in reverse, where a clinical trial based upon an experimental mechanism leads to a whole expansion of science as applied. And the driving force really is the clinical trial. I suspect if that had not happened, you quite possibly be doing something else, or at least not have the same enthusiasm, which seems to be so justifiable. We have a whole bunch of questions, so I'm just going to pop some of them, and each of you decide how you want to deal with it. One of the questions is, what do you think? Why do you think some patients with NF1 mutations don't respond to the MEK inhibitor? And are they the ones who have a CDKN2 mutation, or are there other mutations? What do you think about that?
And maybe if I start from the clinical side, that's a great question. And I think that's exactly right. I would say that plexiform neurofibromas, clinically, the typical plexiform neurofibromas almost all respond. The magnitude of response may vary, but we've seen shrinkage in almost all of them. However, if a tumor has lost a CDKN2A, and with that bimolecular qualifies as an atypical neurofibroma, while they can respond, these are the tumors that respond less frequently and may continue to grow. Jack, I don't know if you want to add, but I think that's our current thinking.
Yeah, I'm a sort of a believer that it's probably coded somehow in the cancer cell. But, it is complicated because you can imagine, the drug exposure for different patients is different. How much drug can actually get into a particular tumor may be different, even within the same patient, based on sort of how dense it is. So, it's multifactorial. But certainly, I think if it's gotten a CDKN2A lesion, that's much less likely to respond to the MEK inhibitor. And those are the ones we want to identify and come up with a new therapy.
So apropos of that, there's a certain specificity required here for the tumor. MEK participates in cell growth all over the body, and maybe some of the toxicity is related to it. But it really seems extraordinary that the effect on the tumor would, dominate over the toxicity. Are there efforts to try and target the MEK inhibitor to the tumor, even using nano delivery systems, or what's the thinking about that?
Yeah, I'll start, Brigitte, but it's funny you bring that up, or whoever brought it up. It's an incredible idea, and I think we had a meeting a couple of weeks back where it was sort of, oh gosh, we should really work on this. I think the detailed understanding of those tumor microenvironments and the targets that are there are going to help us define the right strategy to deliver a drug in a better way. So that's, I think another sort of byproduct of having this sort of detailed understanding of the environment, because now you can imagine it becomes an engineering problem. How do you get more drug to that region? And that's what I really love, is that sort of, you understand the mechanism and then you can engineer your way to fixing it.
There was a very interesting talk 2 weeks ago that Sangeeta Bhatia from the bioengineering department at MIT gave, dealing in part with such issues and studies they've done using nanotube deliveries and a specific protease urinary test, which is quite interesting. There is a question about environmental factors and whether they influence either the progression of the tumor or the responsiveness to therapy. Specifically, the sun was mentioned. Is there any environmental information that gives some clue about that?
So I'm not aware of really good clues. There have been thoughts about vitamin D and sun exposure, and many, for example, of the cutaneous tumors are on the trunk, like the density of the tumors, and a thought was, could this be related to lack, for example, of a sun exposure? But I don't think this is really a strong link. And one environmental factor that, or not any environmental, that we try to avoid is radiation in NF tumors, because we believe that radiation to a cell that is already predisposed to develop tumors, may, be at a greater risk for malignant transformation. So we very much try to avoid radiation in NF1 patients unless it's clinically needed. And also radiation can cause or exacerbate vasculopathy, which we can see in NF1 patients. But outside of that, hormonal factors have been discussed. For example, when women are pregnant, some of them have described that thousands of cutaneous tumors erupt during that time. And I definitely had like 1 or 2 patients who told me they were diagnosed during pregnancy with NF1. So those are factors that definitely are associated, at least with cutaneous neurofibroma burden.
Are there, there was a question of whether there are, I guess, geographic hotspots for NF1 that may give some clues. I mean, there's certainly many recessively inherited diseases or on islands or remote populations. Granted, this is a more dominant transmission, but are there any hotspots geographically that?
Not that I'm aware of. I'm pretty sure that this has not been described for NF1. Jack, I don't know if you've heard that.
Yeah, I mean, the one of the interesting things about the NF1 gene is it's huge. It's one of the biggest genes in the genome, and you can imagine, the frequency that we see it in the population. People say 1 in 3,000, 1 in 3,500. Just the size of that gene, in some percentage of the population, you're going to get an error that occurs in that fashion. So I don't know of any geographic regions, but it is interesting to think about, this is a huge gene with a lot of opportunities for things to go wrong, in my thinking.
So you mentioned that neurofibromin is a GTPase activating protein. Is it circulating in blood?
I don't actually know the answer to that, Brigitte. I don't know if people have looked in the original studies that they looked for it.
I would have to pass on this one. I don't know. That's a great question.
It is sort of an intracellular protein, so I don't think of it as secreted, but you know, I don't know that we've ever looked in the serum samples that we've gotten.
And neurofibromin is synthesized by what cells?
It's ubiquitously expressed, so it's sort of all across. Every cell lineage will have sort of NF1 expression, so it's not restricted to particular lineages.
So would it be in hepatocytes, for example, or some?
Yep. It's everywhere. It's an important protein in normal cells and all different lineages. Yeah.
So there's another, let's see, another question here about, there is communication between the mTOR and the MEK-RAS pathway. So is there a role for PI3 kinase in these responses? And there are now various PI3 kinase inhibitors. Is that worth investigating?
Yeah, I could say that you know, certainly that pathway is also activated. It may perhaps in a different way, and that was some of the rationale behind that MPNST trial where we tried to add a MEK inhibitor plus an mTOR inhibitor. The problem with those two pathways is when you start to inhibit both of them, the toxicities sort of go very high. And so, you know, you can imagine in a benign condition of plexiform neurofibromas, you wouldn't tolerate much toxicity at all. And that's one of the benefits of the selumetinib is that toxicity profile was fairly well handled. Brigitte, I don't know if you have other ideas.
Yeah, no, I think I would bet that you know, the preclinical investigators would have looked at PI3 kinase inhibitors as well, and it would be definitely something interesting to explore in combination with the MEK inhibitor in particular. Jack has a great point in the patients who have the histologically benign tumors, especially in the young kids, where it is not an immediately life-threatening condition. Patients will not be as likely to tolerate as much toxicity. They may say, this is too much, you know, I'll stop. And a patient who has an MPNST that is aggressively growing, patients are much more likely to put up with the toxicities that they see in hopes to achieve better responses. So that's definitely something to consider as we develop medicines for these tumors.
So we have a few, I don't know what I would call general clinical related things. One, does the American Academy of Pediatrics really see to it that pediatricians know something about NFF1? I mean, are you confident that most pediatricians look for it, know about it? And if not, how do you disseminate the information?
Yeah, I mean, having been through pediatric residency, this is something that you do look for as a general pediatrician. And the skin findings are so stereotypical that if you see, you know, multiple cafe au lait spots or some of these other really unique clinical findings, it's ingrained in the pediatrician's head. This is NF1, and so I do think, you know, this is a general pediatrician's diagnosis in most cases.
So another practical question. So if the FDA has approved the use of the MEK inhibitor, question practical. Is it covered by insurance? And how much does it cost? Do you have any idea about that?
Yeah, it's really interesting because we talk with AstraZeneca, they developed the selumetinib. I still can't give you a precise answer, but I do think there is coverage by insurance, and there are a number of mechanisms for patients that don't have the means to get access to the MEK inhibitor. So I can't tell you what the cost is. I would expect that it's not inexpensive because most of the drugs that, in this area, like receptor tyrosine kinase inhibitors and so on that are developed are really quite expensive. The interesting aspect in NF1 is that we have patients who've been on this for years. And so it is really like a chronic medicine. But what is very reassuring talking with the company is that there are a number of mechanisms that help patients get access if they don't have the resources. So sorry, I can't answer the precise question.
Do patients relapse when they're on the drug?
So patients who stop taking the medicine, for example, adolescents who don't like the acneiform rash and they may stop taking it, the tumors will likely grow. We have very few patients with the benign tumors who will develop progression on treatment. There are a few. We certainly have seen relapse or progression in patients who undergo dose reduction for toxicity. So the relatively small number of patients who have a dose reduction, some of them will have growth of the tumors because they don't seem to get the adequate dose. What we also have seen is if we have to hold for a toxicity or for surgery or some reason, and the tumor may regrow, that typically the tumor will respond to the MEK inhibitor when we restart it. So those are some interesting observations.
So there's little evidence for the development of real resistance, meaning if a person takes it,
That is correct. Yeah. For the benign tumors, that may be different for the cancer tumors, but as I said, in the MPNSTs, we've not been lucky enough to have responses that we can actually then see the resistance afterwards.
Do patients with NF1 become pregnant, or do they usually choose adoption?
They absolutely can have children, and yeah, absolutely. They can have children, offspring. We have a number of families, where we have offspring, kids with NF1 and without NF1, yes.
So they all have then some form of, are they all by in vitro fertilization? And
no. So the diagnosis of NF1, you have about half of the patients we have a family history of NF1 where either the mom or the dad have NF1 and they know about it or they don't know about it. I would say the majority would know that they have NF1. And the other ones are spontaneous mutations that occur.
So it's not that they have prenatal testing like associated with in vitro fertilization of appropriate.
There is a ability to do prenatal testing, for the presence of NF1. For example, if you have a family history of NF1 and we want to become pregnant and your partner has NF1 or you have NF1, I think there are a number of, issues which mainly relate to the lack of genotype-phenotype correlations. We have patients where, for example, a family member, the mom may be very mildly affected, but that doesn't predict that the child will be mildly affected. This is one of the big problems for people with NF1, that there's so little predictability, with the exception of very few existing genotype-phenotype correlations.
So amongst the many other omas affecting particularly the central nervous system, meningiomas and acoustic neuroma and all of that. Are they all related one way or another to NF1 or NF2?
So they, I would say not all of them, but so in NF1, we see gliomas more frequently. In NF2, which is on chromosome 22, so completely different genetic basis, we see bilateral vestibular schwannomas. We see ependymomas, meningiomas, and then in schwannomatosis, which again has a different genetic basis, we see schwannomas. They on imaging look quite similar, but they have a different and distinct genetic basis. And then obviously we have sporadic ependymomas, meningiomas without a genetic basis for it.
Well, when you say they're sporadic, has that actually been tested? I mean, could they be some, I don't know, heterozygote form of mutation that's a susceptibility? Could they all be related, or have they actually been so examined?
I'm pretty sure they have been examined, and it's true, sporadic, at least NF1, NF2, and schwannomatosis, a genetic predisposition would have been ruled out.
Should there be neonatal screening for NF1?
I wonder how easily that would be done, because of one is the large number of NF1 mutations that can occur, but I think the second one would be really the consequence, because we have people with NF1 who grow up, and you saw our patient who is a wonderful, bright and intelligent young woman. We have patients who are very mildly affected, patients who are severely affected, but I think one of the issues is that there's such a broad spectrum, and I think that would be one of the issues with neonatal screening. That what is your consequence from this? And I think that would be important you to think about when you embark on this.
We also have a personal question for you. How did you become interested in this type of study?
In the NF1 story? Yeah, honestly, it's not really cool, but it was because I knew there were all these drugs out that target RAS, and we thought this is going to be helpful for these patients. My colleague, Dr. Adamson, had actually enrolled patients with NF1 on some other treatment trials, and I literally thought this is going to be an easy thing. We have farnesyltransferase inhibitors, they block RAS pathway activation, and it seemed so logical to try. And this really then opened up a completely new area, and it engaged me in learning more about NF1, understanding this is not cancer, and also learning this is not as easy as I thought. And the relationship that we established with our patients has actually helped, sustain this. They stay with us for years. I have kids that were 3 years old, and now they're 23 years old. And I think once you get into the field, you just get hooked with it, and now Dr. Shern is hooked too, which is wonderful, because he'll hopefully, make the progress that we failed to make to date.
Well, I think, personally speaking, the progress that Jack described is breathtaking in its potential.
Mm-hmm.
If I were much younger and smarter, I'd apply to be a postdoc in his lab.
Maybe you get a job, and I think
I'll take you.
So what is, maybe a last question. This work has opened a really Pandora's box of research possibilities, therapeutic possibilities, help for patients who previously had very little in understanding of the disease as well as in treatment. So I assume this is also a global, if not a national effort. So maybe you would explain to us, like, how you go from being a single lab, granted in the greatest lab place in the world, but nevertheless, but you're dealing with a relatively rare disease that's all over the world. How do you go about marshaling all of the opportunities and talents that exist? And what are the mechanisms that you use to bring this community together? And is there really support for it?
Yeah, I mean, I think it's, and Brigitta's a master at collaborations, and I sort of learned from her. And, you know, I think this community, there's something very unique about this community. And it's driven a lot by the patients and their families. They're committed to doing better for this. And that attracts people that are creative and collaborative. And you don't find that in every disease type, but this particular one, it's a remarkable thing. And Brigitta has a slide she can tell you about where, you know, her conference that they started I guess
in the 80s, yeah.
In the 80s, and just the numbers of people that are now sort of flocking to work on this because of this. And I think
it's really wonderful to see that this is an international collaboration. We have annual meetings where people from all over the world come. It's a competitive field. It's gotten a lot more competitive. Our advantage here, I think, at the clinical center is that we indeed can bring patients. We can do whole body MRIs that cost $10,000 at the outside. It shouldn't, but it does. And we have the luxury that we can follow patients meticulously and then have the basic collaborators at the same time. And I think this really gave us the advantage when we developed our clinical trials. But as Jack said, without the patients being committed to saying, yes, I come for this medicine, I get every 4 months an MRI, I get a sleep study, I get a range of motion study, I answer all of these questionnaires. Without their commitment, we would not have an FDA-approved treatment.
Well, that's wonderful. And it's really very exciting. So, you know, on behalf of, I'm sure, a large number of people who are tuned in all around the world today, I think I'm not out of line to expressing our thanks, our gratitude to both of you and to Heather, and admiration for the tenacity, creativity, and hope that you bring to this field. So thank you very much.
And thank you for the opportunity to attend today. It's been a lot of fun for us.
Thanks for having us.
See you around. Thank you.